everyone. Today I am going to explain about adverse drug reactions. What is an adverse drug reaction? According to WHO, World Health Organization, an adverse drug reaction ADR may be defined as any response to a drug that is noxious. Noxious is harmful, causing harmful effects, and unintended, which is not intentional, and that occurs at doses used in man for the prophylaxis, that is for prevention, diagnosis or therapy of a disease, or for modification of physiological function. However, the definition does not take into account the adverse effects caused by overdose, poisoning, drug abuse, and errors in administration of drug. So overdose of a drug, poisoning, intentional or accidental, drug abuse, and medication errors while administration of drug do not come under adverse effects. So let's see about the classification of ADRs. ADRs are broadly divided into two types based on the traditional classification and novel classification. So the traditional classification is as follows. ADRs can be divided into three types according to traditional classification. Type A, or predictable or augmented. Predictable, that is, we can predict that this kind of side effects will be occurring, this kind of adverse events will be occurring if we administer this particular drug. Augmented, that is, increased effect of the drug. Type B, or unpredictable or bizarre. So unpredictable, these kind of ADRs are unpredictable and they cannot be predicted. So we cannot tell this kind of ADR will occur with administration of this kind of drug. Bizarre, bizarre means unusual or strange. Then the third type is miscellaneous effects. So under type A, or predictable or augmented adverse drug reactions, there are 5 subtypes of ADRs. The first one is excessive pharmacological effects, secondary pharmacological effects, sudden drug withdrawal effects, side effects, and intolerance. Under type B, or unpredictable or bizarre, there are 2 subtypes, idiosyncrasy and allergic drug reactions. Under miscellaneous, there are 4 subtypes of ADRs, that is genetically determined toxicity, carcinogenicity or mutagenicity, drug-induced disease, and teratogenicity. The next classification of ADRs is novel classification. Wills and Brown have classified ADRs into 8 categories according to their mechanisms. Type A is augmented, type B bugs, type C chemical, type D delivery, type E exit, type F familial, type G genotoxicity, type H hypersensitivity. Since the syllabus of 4th BPharm 7th semester pharmacy practice has covered only the traditional classification, I will be explaining in detail about the traditional classification of ADRs. So the traditional classification, in this first type is type A ADRs. This type of adverse drug reactions are also known as predictable or augmented adverse drug reactions. Under type A, the first type is excessive pharmacological effects. Toxic effects result when the drug has been used in excessive doses or has been used for prolonged time periods. So when we use the drug in excessive doses, not in normal doses but in excessive doses, if the patient is using the drug, and if the patient is also using the drug for a prolonged time period, due to which the pharmacological actions of the drug gets prolonged. Overdosage of a drug may be caused directly or relatively. So it is caused directly when the drug is ingested by accident or for homicidal, that is with the intention of murdering someone, or suicidal intentions, that is murdering of self, whereas it occurs relatively when the normal dose of a drug is given to a patient with impaired tissue function, like in case of liver failure, renal failure. In such cases, there is impaired tissue function in the patient and the drug cannot be metabolized or eliminated properly. So it leads to excessive pharmacological effects. Example, normal doses of gentamicin in renal failure may precipitate toxic effects. Gentamicin is an antibiotic. When it is given in renal failure patients, it exhibits toxic effects even in normal doses. This is an example of excessive pharmacological effects which has occurred relatively. The toxic effects can result when the functioning of the drug gets altered. Example, atropine, which is a painkiller analgesic and is used for reduction of inflammation. In high doses it causes delirium. Delirium means the patient is in a state of confusion, disoriented, not able to think or remember clearly. So high doses of atropine causes delirium. When the drug has led to tissue damage, example, overdosage of paracetamol leads to hepatic necrosis, that is death of the liver cells. So during COVID condition, a lot of public have taken a lot of dolo, which has led to hepatic necrosis. So if you take a lot of paracetamol or dolo, it will lead to liver failure, hepatic necrosis. These toxic effects can be extensions of the therapeutic effects of the drug or may be unrelated. So the toxic effect can be related to the therapeutic effect or pharmacological effect of the drug or may be unrelated. So examples of toxic effects are barbiturates, which are sedative hypnotics, can cause coma, can lead to coma. Digoxin used in heart failure can lead to atrioventricular block. Heparin, which is an anticoagulant, can lead to bleeding, bleeding of the gums, intestinal bleeding, nose bleeding from the nose, etc. Morphine, which is a painkiller analgesic, can cause respiratory failure. Emitin, which is used for induction of emesis, that is vomiting, and it is also an antiprotozoal. So it can cause damage to the myocardium. Myocardium is the muscular tissue of the heart. Streptomycin, which is an antibiotic, can cause vestibular damage. Vestibular damage is the inner ear and the CNS are connected. So it maintains the balance in the position while standing, while walking. It maintains balance of the body. So when there is vestibular damage, the person won't be able to walk with a proper balance. So the person won't be able to walk steadily. Poisoning and its treatment. Whether the poisoning is intentional or unintentional or accidental, the poisoning needs to be treated. Excessive exposure to or ingestion of drugs, industrial chemicals, insecticides, etc. may cause harmful effects on vital organs of the body and may even result in death. These drugs, which have life-threatening effects on human body, are called as poisons. So toxicology is the branch of science which deals with the study of poisonous effects of drugs and other chemicals. So how do you treat this poisoning? The general supportive measures to be used during poisoning have been outlined below. By employing a selective antagonist, the poison can be identified. So initially, the healthcare professional needs to identify which poison has been consumed by the patient. So to identify that, they will be using selective antagonist, which goes and binds to the poison and identifies the poison. Then next, second step is airway maintenance. The airways should be maintained clear by removing any obstructing substances like vomiters, mucus, etc. And the body parts exposed to poison like skin, eyes, etc. should be cleaned properly. Then the third step is maintenance of ventilation. Maintenance of adequate ventilation is necessary as hypoventilation causes hypoxemia. So when the patient is not able to breathe properly, it can lead to reduced oxygen levels in the blood. That is nothing but hypoxemia. While hyperventilation, that is excessive breathing, can lead to alkalosis and hypotension, reduced BP. Hence, the volume of 400 ml and minute volume of 4 liter per minute are maintained during poisoning. Then, whatever the poison has been taken, it should be eliminated from the body. So, what the healthcare professionals do is emesis induction and gastric lavage. Emesis induction is induction of vomiting, and gastric lavage is cleaning of the GIT, gut will be cleaned. Induction of vomiting and gastric lavage ensures elimination of the drug and therefore prevents further absorption. So the drug should not be, the overdose of the drug or any poison, it should not be further absorbed into the bloodstream. So to prevent that, emesis induction and gastric lavage is done as the fourth step. Emesis is usually induced by apomorphine or ipecac syrup. In poisoning due to CNS stimulants, corrosive drugs that cause damage, kerosene, and in comatized patients, these methods of drug elimination are not used as they may cause aspiration into the lungs. So, these drugs can cause aspiration into the lungs. That is, the excessive drug can enter into the lungs. So in such patients, we will not prefer emesis induction and gastric lavage to prevent aspiration into the lungs. Then fifth step is fluid and electrolyte balance. It is maintained by 0.9% weight by volume isotonic saline or 5% weight by volume isotonic saline glucose, so that proper blood circulation occurs and cardiac output is restored. The blood sugar levels are also maintained by dextrose infusion. Then decontamination, next step. The absorption of poisons into the blood is prevented by the following methods. Universal antidote. It is made up of magnesium oxide, milk of magnesia, strong tea and burnt toast in the ratio 1:1:2. Then second method is by charcoal. It is administered in the form of suspension made by dissolving 40 grams charcoal in 200 ml water. What charcoal does is it binds to the unabsorbed drug and causes its elimination. However, charcoal is ineffective in absorbing strong acids, alkalis, iodine, cyanide, alcohols, organic solvents, etc. Then seventh step is administration of antidotes. Antidotes may be used to treat specific types of poisoning. These antidotes could be receptor antagonists. So there are specific antidotes for specific drugs. Specific poisons have specific antidotes. So what antidotes do is they go and bind to the receptors that the drugs or poisons are going to bind to. So they go and bind in the place of the poison or the drug to the receptor. So there is no place for the poison or drug to bind and act on the receptor. That is how they act as antidote, like receptor antagonists. Then they act as chelating agents. That is, they go and bind to the poison or drug itself and form a chelate. So the chelate won't be able to bind to the receptor and show its action, or other specific antibodies. So they can also go and bind to the antibodies and form antigen antibody complex so that the drug or the poison do not act on the receptors, which reverses the actions of the poisons. Examples of antidotes are paracetamol poisoning is treated by acetylcysteine. Then mercury, which is a heavy metal, poisoning is treated by dimercaprol, which chelates the Hg plus ions. Here chelate formation can be seen. Morphine poisoning. Morphine is a analgesic. So morphine poisoning is treated by naloxone. Anticholinesterase. Anticholinesterase is used in Alzheimer's disease. So its poisoning can be treated by atropine. Then eighth step is promotion of drug elimination. By forced diuresis is one method. To prevent the reabsorption of poison and to rapidly eliminate it from the body, forced diuresis can be carried out using furosemide, mannitol, which are diuretics. However, due to its low efficacy, forced diuresis is not being employed. Then next, another method is by ionization of drugs. Drug elimination can be promoted by inducing its ionization. Acidic drugs like phenobarbital, salicylates, etc. get ionized in alkaline pH. Therefore, their reabsorption through kidney tubules is prevented by increasing the urine pH using sodium bicarbonate. Then basic drugs like amphetamine, pethidine, etc. get ionized in acidic pH. Hence, reabsorption is prevented by decreasing the urine pH. Then next method is by hemodialysis and peritoneal dialysis. This is carried out in patients who do not respond to conventional methods of treatment. Procedure involves passing the patient's blood through a column containing charcoal or other suitable adsorbent. Drugs which can be removed by dialysis are barbiturates, diphenhydramine and phenytoin. Phenytoin is an anticonvulsant, diphenhydramine is an antihistamine. Then under type A, the second type of adverse effects are secondary pharmacological effects. Primary therapeutic action of the drug may also show certain indirect consequences called as secondary effects. So the drug is intended for primary therapeutic action, but it can also lead to secondary effects. Examples are activation of latent tuberculosis occurs upon administration of corticosteroids as the defense mechanisms of the host decline. So usually corticosteroids mechanism is by suppressing the immune system. They are immunosuppressants. So they are used in inflammatory conditions. Since the immune system is getting suppressed, the host defense mechanisms are reducing. So it will lead to opportunistic infections like latent tuberculosis. Then tetracyclines used to inhibit the bacterial flora causes superinfections as a secondary effect. Then third type of ADR in type A is sudden drug withdrawal effects. These effects occur because of drug dependence or abrupt cessation of drug therapy. So certain drugs can cause drug dependence. The patient will be addicted to the drugs. So sudden withdrawal of the drugs or abrupt cessation, stopping of the drug can lead to effects, adverse effects. Such drug withdrawal results in exacerbating and worsening of the disease condition for which the drug was being administered. Examples: discontinuing the use of clonidine causes severe hypertension. Clonidine is an antihypertensive. So when we suddenly discontinue clonidine, it can lead to severe hypertension. Discontinuing the use of beta blockers leads to overpowering symptoms of angina pectoris and myocardial infarction. Upon sudden discontinuation of anti-epileptic drugs, the occurrence of seizures intensify. So we should not suddenly withdraw the drugs. it can lead to worsening of the disease condition that they are treating. Then fourth type is side effects. The undesirable effects of a drug which are observed along with the intended pharmacological action are called as side effects. These are generally mild and can be tolerated. So the patient is able to tolerate the side effects. From a drug's pharmacological profile, its common side effects can be predicted. These side effects are dose related, that is, as the dose of the drug is decreased, the side effects decreases. Sometimes a therapeutic effect may be associated with a side effect. Examples are the diuretic action of acetazolamide causes acidosis as a side effect. It is due to the fact that action of acetazolamide causes elimination of bicarbonate ion, therefore increasing the acid content of the body. So during diuresis, fluids from the body that are accumulated in the body should be eliminated. So during this process, the acetazolamide eliminates bicarbonate ion. So it leads to increased acid content in the body and it leads to acidosis. The anti-secretory action of atropine when administered as a pre-anesthetic medication causes dryness of mouth as a side effect. So before giving anesthesia, to stop the salivary secretions, they will be administering atropine for its anti-secretory action, but as a side effect it causes dryness of mouth. Then promethazine when given as an anti-allergic drug produces sedation as a side effect. Promethazine is an antihistamine, so it is given in case of allergic conditions, but it produces sedation as a side effect. The effect of a drug may be therapeutic in some context but referred to as a side effect in another context. So the therapeutic effect so the side effects which occur due to the drugs can have therapeutic effects also. Let's see the examples. Codeine as an antitussive. Codeine is actually used as a cough suppressant, that is antitussive. It causes constipation as a side effect, but as a therapeutic effect it is given in traveler's diarrhea. Since it causes constipation as a side effect, we can actually prescribe the drug codeine for traveler's diarrhea as a therapeutic effect. Another example for such scenario is minoxidil, which was actually used for hypertension, but it used to give a side effect of excessive hair growth. So they started using minoxidil for hair growth purpose. Other examples of side effects are estrogens, which have anti-ovulatory action, therapeutic action, causing side effect of nausea. Then sulfonamides having therapeutic action of antibacterial can cause side effects like hypoglycemia and acidosis, reduced glucose levels in the blood and increased acid levels in the blood. Then fifth type is intolerance. Sensitivity towards a drug is measured using Gaussian frequency distribution curve. The individuals who appear on the extreme left side of this curve show intolerance as they experience toxic effects even in the therapeutic doses. Such individuals are said to be highly sensitive to certain drugs. So even at therapeutic doses, normal doses, some of the individuals will be experiencing intolerance since they are sensitive to the drug. Examples are vomiting and abdominal pain by only one tablet of chloroquine, which is an anti-malarial in some individuals. Ataxia, which is a neurological disease where we can see loss of muscle control upon only few doses of carbamazepine, which is an anti-epileptic agent used in seizures. Then muscular dystonias, which is uncontrollable muscle contractions seen in children with single dose of triflupromazine, which is an antipsychotic. Then coming to type B ADRs, this type of adverse drug reactions are also known as unpredictable or bizarre adverse drug reactions. The first type is idiosyncrasy. The abnormal responses shown upon administration of drug because of genetic defects in the patient are called as idiosyncrasies. So idiosyncrasies are due to genetic defects in the patient. These responses are bizarre and do not occur in every patient. The affected individual react in an abnormal way towards the drug. The study of idiosyncrasies is called as pharmacogenetics. Example, asthma, vascular collapse, that is circulatory failure, cramps, that is painful muscle contractions, diarrhea, purpurea. Purpurea is the appearance of purplish spots over the skin because of internal hemorrhage, are observed upon administration of quinine or quinidine in certain individuals. Quinine is an anti-malarial, quinidine is an anti-arrhythmic drug used in abnormal heart rate. Then polyneuritis, that is inflammation of the neurons, occurs with isoniazid, which is an antitubercular drug, in slow acetylators, whereas drug resistance and failure of drug response seen in fast acetylators. Then resistance to vitamin D in certain individuals. Malignant hyperthermia, that is increased body temperature, is observed with halothane, which is a general anesthetic, as an abnormal response in few people. Hereditary methemoglobinemia, presence of blood pigments oxidized from ferrous to ferric form in blood. Idiosyncrasy is also observed in patients who either completely lack or are deficient in a particular enzyme. Example is hemolytic anemia results when usual therapeutic dose of primaquine, which is an antimalarial, is administered to a patient with deficiency of G6PD enzyme, that is glucose 6-phosphate dehydrogenase enzyme. Because of the lack of or deficiency of this enzyme, it leads to hemolytic anemia in patients administered with primaquine. So hemolytic anemia is breakdown of the RBC. Then second type in type B reactions is allergic drug reactions. An inappropriate immune response by the body to a drug is called as drug hypersensitivity or allergy. The allergy is not dose related and is not dependent upon the pharmacological profile of the drug. So this is why these reactions are unpredictable, since it is not dose related and also not dependent on the pharmacological profile of the drug. It occurs due to the sensitization of the patient upon first exposure to a drug acting as allergen. So upon first exposure, the drug acts as an allergen. Upon subsequent administration of the same drug, so second exposure, the immune system gets activated, thereby producing antibodies against the drug. The antigen antibody reaction results in rashes, pruritus. Pruritus is itching. Edema. Edema is accumulation of fluids in the body. And wheezing. Wheezing is whistling sound while breathing. So there are types of allergic drug reactions or hypersensitivity. First type is IgE mediated hypersensitivity or type 1. This is also referred to as immediate or anaphylactic hypersensitivity. it occurs immediately within minutes and disappears after 2 to 3 hours. The first exposure to a foreign antigen, which could be a drug or chemical substance, causes the release of IgE antibodies. So because of the first exposure of the drug, there will be release of IgE antibodies. These IgE antibodies bind to the Fc receptors present on cell surface of mast cells and basophils. So IgE antibodies go and bind to Fc receptors on mast cells and basophils. Second exposure to the same foreign antigen causes degranulation of mast cells and activation of heparin, histamine and serotonin, which are the inflammatory mediators. So second exposure to the same kind of foreign antigen will cause degranulation of the mast cells. The activated leukocytes destroy the foreign antigen, which is accompanied with vasodilation. So blood vessels will be dilated, contraction of the smooth muscles and increased calcium influx. The allergy, if untreated, causes anaphylactic shock. So anaphylactic shock is a serious allergic reaction which can also lead to death if untreated. Basophils also release histamine and heparin. Other inflammatory mediators released are prostaglandins, leukotrienes, platelet activating factor, PAF, etc. Examples of foreign antigens or allergens are dust, pollen grains, drugs like penicillins, anesthetics, milk, nuts, eggs, insect products like bees venom, animal hair, mouse spores, etc. So this is the diagrammatic representation of immediate or anaphylactic hypersensitivity type 1. So here the allergen specific IgE, which is the green one, allergen specific IgE is getting binded to the allergen, and then the Fc receptor for IgE, the allergen specific IgE is going and binding to the Fc receptor for IgE, and then mast cell, this is the mast cell, degranulation of mast cell is happening, and it leads to release of inflammatory mediators. Then symptoms are anaphylactic shock, rhinitis, runny nose, facial flushing, that is the face becomes red because of flow of blood into the face, itching and nausea, vomiting, swelling of mouth and tongue, airway obstruction, low BP, wheezing, etc. Treatment: administration of epinephrine, antihistamines, corticosteroids, cromolyn sodium, etc. Antihistamines can be used in allergic rhinitis and conjunctivitis. So they reduce the allergy. Prednisolone in asthma. Prednisolone is a corticosteroid, so it reduces the immune system. So in asthma it can be used. Aminophylline in chronic bronchitis and asthma. Aminophylline is a bronchodilator. So in chronic bronchitis and asthma, the patient will be experiencing breathlessness. So to improve the breathing, they will be giving aminophylline, which is a bronchodilator. It dilates the bronchi and bronchioles of the lungs. Then type 2. Type 2 reactions are antibody mediated hypersensitivity reactions. This type of hypersensitivity is also referred to as cytotoxic hypersensitivity. It occurs within 72 hours of drug administration. So this type 2 does not occur immediately, it takes time. It occurs within 72 hours of drug administration. Upon first exposure to a drug, the drug or its metabolite gets converted into an antigen by getting bound to host proteins, and the antigen so formed is considered as a foreign substance, resulting in activation of IgG and IgM antibodies. So here we can see the release of and activation of IgG and IgM antibodies. Upon second exposure to the same drug, these antibodies form a complex with the antigen to form antigen-antibody complex, resulting in the release of chemical mediators like heparin, histamine from tissue and mast cells. Thus, cytolysis occurs, leading to the destruction of foreign antigen. So, cytolysis is breakdown of the cell. So, mast cells will be destroyed. Examples of type 2 hypersensitivity reactions include ABO transfusion reactions. So, AB blood group and O blood group should not be mixed. During blood transfusion, we should not mix AB blood group and O blood group. It will lead to hypersensitivity reactions. RH hemolytic disease, drug induced hemolytic anemia, etc. Symptoms are fever, systemic lupus erythematosus, which is an autoimmune disorder, hemolysis, that is breakdown of the RBC, thrombocytopenia, decreased platelet count, liver, kidney, muscle damage, aplastic anemia, that is damage to the in aplastic anemia we can observe damage to the bone marrow. So, production of RBC, WBC as well as platelets will be reduced. Then agranulocytosis, where we can observe reduced leukocytes and neutrophils. Neutropenia and leukopenia will be there. So, this is the diagrammatic representation of type 2 hypersensitivity reactions. Antibody dependent cellular cytotoxicity, ADCC. So, this is the target cell. To the target cell, antigen is going and binding. This is antibody, IgG antibody. So, IgG antibody along with the target cell and the antigen, IgG antibody is getting attached or bound to the Fc receptor. So, these are the natural killer cells. When they bind to the target cell, they will be destroying the target cell. Natural killer cells will be activated and they will be destroying the target cell. It leads to cytotoxicity. Then the third type is immune complex mediated hypersensitivity. This type of hypersensitivity is also referred to as retarded hypersensitivity because though this allergy begins after 72 hours, it generally gets relieved within 1 to 2 weeks. So, similar to type 2, it starts within 72 hours of administration of drug, but it gets relieved within 1 to 2 weeks. In this, the antibodies like IgG binds with foreign antigens and form an immune complex. These complexes are usually eliminated by reticuloendothelial system. However, these complexes may get deposited on the vascular endothelium and act like allergen, thus initiating an inflammatory response. Examples: glomerulonephritis. So, the glomerulus and the nephrons are inflamed. In glomerulonephritis, we can observe an inflammation of the glomerulus and the nephrons. Rheumatoid arthritis, inflammation of the knee joint. Then systemic lupus erythematosus, Arthus reaction. Arthus reaction is formation of a hard, painful swelling in the inside at the site of injection. And serum sickness, where we can observe joint pains and fever. Then symptoms are rashes, serum sickness, nephritis, inflammation of the nephrons, Stevens-Johnson syndrome, where we can observe reddish color rashes on the skin. Then polyarteritis nodosa, that is arteries will be inflamed, inflammation of the arteries of the heart. Then fourth type is delayed type hypersensitivity. In this type of hypersensitivity, the T lymphocytes carry Antigen specific receptors which get activated when they come in contact with an antigen, leading to the formation of lymphokines. So in type 4 we can see the formation of lymphokines. These lymphokines result in inflammatory responses which take more than 12 hours to develop by attracting granulocytes. That is why it is called delayed type hypersensitivity, since it takes more than 12 hours. Examples are photosensitivity reactions, contact dermatitis, skin rashes, fever, etc. So, we will see what is photosensitivity. It is confined to the skin and occurs because the drug sensitizes the skin to UV radiation. It is of two types: phototoxic reactions, photoallergic reactions. In phototoxic reactions, the drug or its metabolite accumulates in the skin and absorbs UV radiations of the wavelength 290 to 320 nanometers. This results in phototoxic reactions resulting in erythema, that is redness of the skin, edema, fluid accumulation in the body, blistering, then hyperpigmentation. We can observe in some people, we can observe patches of black spots, that is called hyperpigmentation. And desquamation. Desquamation is skin peeling of the skin. Examples of the drugs causing phototoxic reactions are tetracyclines, tar products, nalidixic acid, which is a antibiotic. And then photoallergic reactions. These occur due to absorption of longer wavelengths. So at shorter wavelength, 290 to 320 nanometers, phototoxic reactions are occurring. If longer wavelengths are absorbed, 320 to 400 nanometers of UVA radiation, photoallergic reactions will occur by the drug or its metabolites after it accumulates in the skin. It is a cell mediated immune response. Manifestations include eczematous or papular contact dermatitis. Examples of the drugs causing photoallergic reactions are sulfonylureas used in diabetes, chlorpromazine, which is an antipsychotic, and sulfonamide, which is an antibiotic. Then cross sensitivity. It may be defined as sensitivity to one drug that makes an individual sensitive to another drug of the same category. So, if the individual is sensitive to one drug, he or she becomes sensitive to another drug of the same category. Examples are, few people are allergic to NSAIDs, non-steroidal anti-inflammatory drugs, which are analgesics. A person sensitive to ibuprofen, which is an analgesic, also shows sensitive to naproxen, which is also an analgesic, as they belong to the same class. Few people show sensitivity towards drugs used as antidepressants. Then cross sensitivity occurs between penicillins and cephalosporins because they have a common beta-lactam ring, and similar spectrum of allergic reactions can be observed. Symptoms are anaphylaxis, skin rashes, eosinophilia, reduced eosinophil count, fever, and gastrointestinal defects are common. Severe urticaria. Urticaria is characterized by redness, rashes, itching, etc. Angioedema, that is fluid accumulation under the skin. Laryngeal edema, larynx, the fluid accumulation in the larynx. Low BP, wheezing may also occur in few individuals. Differences between type A and type B adverse drug reactions. So type A ADRs are caused by hyper or hypo response mechanism. Type B ADRs are caused by genetic or immunological or unknown mechanism. Type A ADRs are very common, type B are less common. Type A ADRs are pharmacologically predictable, but type B ADRs are pharmacologically unpredictable. Type A ADRs are dose dependent response. Type B ADRs, there is no dose dependent response. Type A ADRs cause low mortality rate. Type B ADRs cause high mortality rate. Type A ADRs can be treated by dose adjustment. Since they are dose dependent, they can be treated by dose adjustment. But type B ADRs requires complete withdrawal of the offending drug. So we have to completely stop the drug causing the ADR. Example of type A ADR is insulin induced hypoglycemia. Then type B ADR's example is allergy caused by penicillins when given for the first time. This is very common reaction. With penicillins we can observe very commonly allergic reactions. So for every patient before giving penicillin they will be doing a patch test. Then third type of adverse reactions in traditional classification is miscellaneous effects. Under the miscellaneous effects, the first type is genetically determined toxicity. Genetically determined toxicity is also known as genotoxicity, refers to the properties of chemical agents that damages the genetic information within a cell, causing mutations leading to cancer. So since the drugs are acting on the genetic information within a cell, either the DNA or the RNA, they are causing mutations in the DNA or RNA, it leads to cancer. It is important to note that all mutagens are genotoxic, whereas all genotoxic agents are not mutagenic agents. Basically, chemical agents cause carcinogenesis by inducing mutation in proto-oncogens and anti-oncogens in 3 sequential stages, which are described below. So first it is initiation. Chemical carcinogens transform a normal cell into an initiator cell in the following manner. So under initiation we can see different stages. Metabolic activation. In this step, procarcinogens are rendered metabolically active by monooxygenases of CYP450 enzyme system in the endoplasmic reticulum of the liver. The second step is reactive electrophiles. Following metabolic activation, procarcinogens become electron deficient and hence bind to electron rich portions of the cell like RNA and DNA, etc. Then the third step is target molecules. DNA is the primary target molecule of reactive electrophiles for binding. Binding induces mutations in the genes of target molecule, which in turn transforms a normal cell into a carcinogenesis initiating mutated cell. Then fourth step is initiated cell. When the initiated cell undergoes at least one proliferation cell cycle, the damage induced in the DNA of the cell becomes irreversible and permanent. That is why we cannot cure cancer. It is because the damage is irreversible and permanent. Then the second stage is, first stage initiation we have seen, second stage promotion. In this stage the promoter carcinogens enhance the effect of direct acting and indirect acting carcinogens by causing further clonal proliferation and expansion of mutated cells. So one cell has become cancerous. If one cell is becoming cancerous, it will lead to replication, multiplication and proliferation, expansion of the same cancerous cells. So mutated cells will be expanding and they will be promoting. Then third stage is progression. When the mutated cells undergoes rapid proliferation, they acquire more and more mutations, as a result of which phenotypic features of malignancy related to morphology, molecular features and biochemical composition become evident in this stage. So in miscellaneous effects, the second type of ADRs are carcinogenicity or mutagenicity. Carcinogenicity refers to ability of a drug to cause cancer, whereas mutagenicity refers to genetic defects caused by mutations. Example of carcinogenicity is upon prolonged usage of estrogens by women without progesterone develops endometrial cancer. So estrogens should always be combined with progesterone. If not, the patients will be prone to endometrial cancer. Example of mutagenicity is hereditary methemoglobinemia. Then third type is drug induced diseases. The diseases or disturbances in the normal functioning of the body due to drugs even after their withdrawal and complete elimination are called drug induced diseases or iatrogenic diseases. So here we are completely stopping the drug. We are completely withdrawing the drug and completely eliminating the drug from the body. But still we are observing drug induced diseases, which is also called iatrogenic diseases. Examples are salicylates and corticosteroids cause peptic ulcer. Then isoniazid causing hepatitis. Phenothiazine, which is an antipsychotic causing Parkinsonism. In Parkinsonism, we can observe slow movements, stiffness of the muscles, tremors, postural instability. There won't be balance while walking and standing. Then fourth type is teratogenicity. A teratogen is an agent that has the potential to cause malformations and functional abnormalities in the fetus. So, teratogen is a drug or an agent which can cause malformations and functional abnormalities in the fetus. So, birth defects are due to teratogens. Thus, the common term that encompasses fetal death, structural malformations, functional abnormalities, and abnormal fetal development is congenital anomalies. So, the medical term used for birth defects is congenital anomalies. Out of the numerous drugs scanned for teratogenic potential, only about 30 drugs have been proven teratogenic effects. So, many drugs have been tested for their teratogenic potential. They have found that only 30 drugs have proven teratogenic effects. These teratogens bring about structural malformations that may be fatal, that can cause death or demand surgical interventions. Almost 2% of the children suffering from severe physical and mental retardation were exposed to teratogens in the uterus. The extent of damage affected to the fetus is determined by 4 factors. Physicochemical properties of the teratogen, then dose and route of administration, at what dose the mother has taken the drug. So if the mother has taken higher dose, it can lead to more damage to the fetus. If the route of administration is IV, intravenous, it will be directly, the drug will be directly entering the systemic circulation. So first pass metabolism is avoided. So it can lead to more damage to the fetus. Then fetal stage of exposure. At what stage the fetus is getting exposed? First trimester or second trimester or third trimester. This determines the extent of damage to the fetus. Then genetic composition and biological susceptibility of mother and fetus. Some of the mothers, they are already genetically prone to the diseases. So in such mothers and fetus, if they are already genetically prone and biologically susceptible to the diseases, the extent of damage will be more. So these are the examples of teratogens. Teratogenic drugs, danazole. Danazole is used to treat endometriosis. Endometriosis is formation of uterine layer around the intestines or fallopian tubes or ovaries. So usually the lining should be formed in the uterus, around the uterus. But if the lining is getting formed outside the uterus, it leads to endometriosis. So danazole is used to treat endometriosis. If the time of exposure, any trimester, first, second, third or fourth trimester, any trimester, if the mother is getting exposed to danazole, it leads to virilization of female fetus. That is, the gender of the female fetus completely transforms into male. The female fetus completely transforms into a male fetus. Then spironolactone, which is a diuretic, and cyproterone, which is an anti-androgen. So at any trimester, if the mother get exposed to spironolactone or cyproterone, it leads to feminization of male fetus. So male fetus completely transforms into a female fetus. Then ACE inhibitors, angiotensin converting enzyme inhibitors, which are antihypertensives, when used in second and third trimester, leads to impairment of renal function in fetus and oligohydramnios. Oligohydramnios is extremely low levels of amniotic fluid in the uterus. So it is not safe for the fetus to have extremely low amniotic fluid, because the amniotic fluid protects the baby. Then sulfonamides, end of third trimester, if the mother is getting exposed to sulfonamides, it leads to neonatal hemolysis. Then NSAIDs, non-steroidal anti-inflammatory drugs. When the mother is exposed in the third trimester, it leads to closure of fetal ductus arteriosus. So the heart has arteries. So the arteries which supply blood to the pulmonary veins, in between that there is ductus arteriosus. So exposure to NSAIDs will lead to closure of the fetal ductus arteriosus. So there will be reduced blood flow to the pulmonary veins. Then renal impairment and delayed labor. In order to ease the dilemma encountered by the physicians in prescribing the drugs in pregnancy, the Food and Drug Administration (FDA) has categorized drugs according to the risk factors associated with them. Such an approach is based on the results obtained from both animal and human studies. So to reduce the confusion while prescribing the drugs in pregnancy to the physicians, they have categorized the drug. Food and Drug Administration (FDA) has categorized the drugs according to the risk factors associated. So these this categorization is based on the studies that are done on both human as well as animals, preclinical as well as clinical studies. Category A drugs are considered safe. The category B, C, D are associated with proportionately increasing risks. However, they are commonly recommended to pregnant women. So they will be recommending to the pregnant women, but at low doses. Category X drugs have high teratogenic potential and hence are contraindicated in pregnancy. So category X drugs should not be prescribed during pregnancy. They are contraindicated. So category A drugs. These drugs have failed to exhibit any risk towards the fetus in first trimester. So they are considered safe. Further possibility of any fetal effect is also less, both of which were proven by controlled studies in women. So we have proper established studies that category A drugs are safe during pregnancy. So examples of drugs are acetaminophen, nothing but paracetamol, meperidine, which is an opioid analgesic, painkiller, ephedrine to treat low BP during anesthesia. So when the patient is administered anesthesia before surgery, the BP falls all of a sudden. So they will be administering ephedrine to the patient. Then digoxin used in heart failure, lidocaine local anesthetic, heparin anticoagulant, furosemide diuretic, amikacin, antibiotic, propranolol, beta blocker, clonidine, antihypertensive. Then category B, either no fetal risk was evident in animal reproduction studies, or the fetal adverse effect was shown in animal reproduction studies but was not provided in controlled studies in women in first trimester. So examples of such drugs are diphenhydramine, which is an antihistamine, ibuprofen, painkiller, nitrofurantoin used in UTI, urinary tract infections, indomethacin, which is an NSAID. Category C, either animal control studies exhibited fetal adverse effects but there were no control studies in women, or no control studies have been performed in both animals and women. These drugs should be prescribed only when the benefits outweigh risk to fetus. So if the benefits are more than the risk, then this kind of the C category drugs will be prescribed. Examples are bismuth subsalicylate, which is an antacid used to treat ulcers. Then chloramphenicol used in conjunctivitis of the eye. Codeine, which is an antitussive, cough suppressant. Epinephrine, which is an antihistamine. Then fluconazole, antifungal. Phenylephrine, antihistamine. Quinolones, antibiotics, fluoroquinolone, etc. These are antibiotics. Rifampin, anti-tubercular drugs. Oral sulfonylureas used in diabetes. Then category D, the risk associated with the drug is high. However, its use is justified in certain life-threatening situations or in severe diseases in which the other safer drugs either prove to be ineffective or cannot be used. So, category D drugs have high risk, but we can justify the use in the mother, because if the mother is suffering from some life-threatening condition or severe disease, and if the other drugs, alternative drugs, are not effective in that mother, they are not working for the patient, then they have to go for category D. Examples are amiodarone, which is an antiarrhythmic drug for irregular heartbeat. Amitriptyline, which is an antidepressant. Carbamazepine, anti-epileptic. Hydroxyurea, used in cancer. Imipramine, antidepressant. Penicillamine, antibiotic. Phenytoin, epilepsy. Propylthiouracil, used in hyperthyroidism. Then category X, either the fetal abnormality was evident in both human and animal studies, or the fetal risk was evaluated based on human experience. So there are established studies in both human and animal studies. Fetal risk was seen. These drugs are contraindicated in women who are or likely to be pregnant. So already pregnant women or who are going to be pregnant, they should avoid taking category X drugs. Examples are danazole, diethylstilbestrol, ethanol, which is alcohol. So alcohol should not be taken by pregnant women. Sodium iodide and iodine, used in iodine deficiency and total parenteral nutrition. And methyl mercury, which is present in fluorescent lights. So pregnant women should not be exposed to fluorescent lights. Then isotretinoin, which is an over the counter drug. So it is available over the counter in medical shops, and it is used for anti-aging purpose and also to treat pimples or acne. So the mothers will be buying the cream without knowing, without any knowledge about it. They will be buying the cream for anti-aging or for treating pimples, but it will definitely affect the fetus. So it is category X drug which should not be prescribed in pregnancy. Then ADRs reporting and management, pharmacovigilance. What is pharmacovigilance? WHO defines pharmacovigilance as science and activities relating to the detection, that is identification of the ADRs, and assessment whether the ADR is caused by the drug or not. So the clinical assessment should be done. Causality assessment should be done. Understanding and prevention of adverse effects or any other medicine related problems. So in pharmacovigilance, medicine related problems are also checked. So medicine related problems means any quality issues with the medicine. If the suppose a suspension has some particles inside it, it is a medicine related problem. So the medicine related problems like quality issues will also be addressed by the pharmacovigilance department. The main aim of pharmacovigilance is to recognize drug related adverse effects by gathering, researching and evaluating data obtained from the patients and other healthcare bodies. So post-marketing pharmacovigilance is an important tool to identify long-term adverse effects which often go unnoticed in clinical trials. Usually in the first 3 phases of clinical trials, they will include healthy volunteers for a shorter periods of time. So the deceased population, studies in the deceased population, special population like children, elderly, pregnant women, will be excluded in the first 3 phases of clinical trials. So post-marketing studies, that is phase 4 pharmacovigilance studies, will help in noticing the long-term adverse effects. Since after marketing of the drug will be used for a long term and it will be used by all the population, we can notice the effects which were not noticed during the clinical trials, first 3 phases of clinical trials. Whatever is not noticed, we can observe those effects in the post marketing phase 4 pharmacovigilance studies. This is because clinical trials are carried out for shorter periods as they are very expensive and are done on healthy human volunteers, excluding children, elderly and patients with complicated diseases who are more susceptible to ADRs. Strict pharmacovigilance should be carried out by healthcare professionals. Potential ADRs can be detected during ward rounds in the hospital or during review of patient's medical profile. The following patients are at high risk of ADRs and should be closely monitored. Patients with renal or hepatic impairment. So patients with renal or hepatic impairment, since liver is the main area for metabolism of the drug, when in patients with hepatic impairment, the metabolism of the drug decreases, the drug stays inside the body. And in renal impairment also, the drug stays inside the body because elimination of the drug is reduced. So it leads to more ADRs. So these patients are at high risk. Patients on drugs known to cause ADRs. So some of the patients are prone to ADRs. They are genetically susceptible or biologically susceptible to the ADRs. So if they are already have a history of ADRs, they are at high risk. Patients on multiple drug therapy. So some of the patients will be having multiple disease conditions. They should be treated with multiple drugs. So when giving multiple drugs, they have a high risk of adverse drug reactions. And patients with any previous medical history of allergenic reactions. So patients who are prone to hypersensitivity reactions, allergic reactions and have a previous medical history, they are at high risk. So here let us know about the history of pharmacovigilance, how the pharmacovigilance system came into existence. So there is an interesting as well as tragic story behind the um, formation of pharmacovigilance system in almost all the countries. So there was a drug called thalidomide. So in 1950s and early 1960s they used to use this drug widely in the pregnant woman for morning sickness. That is, pregnant woman will be having nausea, vomiting sensation and vomitings during pregnancy. So to treat this morning sickness, physicians used to prescribe thalidomide to the pregnant woman during 1950s and early 1960s. It used to be widely, it was used widely in Europe, Australia, Japan, etc. But what happened in 1960s, late 1960s, Dr. Widukind Lindsay and Dr. William McBride, they observed association between thalidomide and congenital malformations. So they observed that approximately 10,000 children were born without limbs, that is without hands and without legs. So this condition is called phocomelia. So Dr. Widukind Lindsay and Dr. William McBride, they have established the association between thalidomide usage and phocomelia. So they have published this information in a journal. Then what happened was, other physicians who have observed similar kind of malformations, congenital malformations or birth defects in children, they have also started writing in journals, publishing in the journals. Then in 1961 they have banned thalidomide in pregnant women. So this thalidomide tragedy is an important event in the history of pharmacovigilance. So from there pharmacovigilance system has evolved. Till then there was no proper system of reporting adverse drug reactions, detection of adverse drug reactions, monitoring, reporting, nothing was there. But the thalidomide tragedy has started an alert to the healthcare professionals for the importance of pharmacovigilance system. Then what is the information required for detecting ADRs? Demographic data of the patients, that is patient's age, sex, height, weight, smoking history, alcoholic history, everything comes under demographic data of the patients. Then details of suspected ADR such as onset and duration. So the adverse drug reaction time of onset, when did the adverse drug reaction start, and for how many days the adverse drug reaction is observed in the patient, the severity, whether it is mild, moderate or severe, severity should also be mentioned. Dose, dose at which the ADR occurred, dose of the drug at which the ADR occurred, frequency, and route of administration of the offending drug and its plasma levels. Then previous medical history of the patients, details of drug therapy, that is OTC drugs, over the counter drugs, as well as present medication. Clinical laboratory data of the patients. This is also important because not all ADRs will show symptoms. There are some of the ADRs which are seen in laboratory data. Like example, hypokalemia. The patient is suffering with a side effect of hypokalemia, where there are no symptoms for that. So we can only observe it in laboratory data. The potassium levels will be reduced in the blood. So clinical laboratory data of the patients should also be required to be collected. The above mentioned information can be sourced from case details and treatment chart of the patients, laboratory data, interaction with the patient himself, and by interaction with other healthcare professionals. The suspected ADR should be documented in the patient's medical record, which helps to alert the physicians that the particular drug is capable of causing an ADR. Moreover, the ADR should be reported to the pharmacovigilance centers. So, when a healthcare professional observes an ADR in the patient, he or she should report it to the peripheral pharmacovigilance centers located in the hospital. The peripheral pharmacovigilance centers will be sending the information to the zonal pharmacovigilance centers. From there, from the zonal pharmacovigilance centers, the information will be going to the pharmacovigilance program of India. The nationwide information will be collected. Earlier, very few novel drugs were discovered in India, and hence the need for a pharmacovigilance system was less. India is now rapidly progressing in the field of drug discovery. There is also a rapid increase in the marketing of foreign branded drugs. These developments have led to the emergence of a strong pharmacovigilance system in our country. So, pharmacovigilance system in India is regulated by Schedule Y of the Drugs and Cosmetics Act 1945. This schedule contains all specifications for conducting trials on animals and humans for the development of a new drug and requirements of clinical trials for the import, manufacture and approval of marketing of a new drug in India. The schedule contains a section on post-marketing surveillance, that is phase 4 studies, which outlines the details about the format to be followed for drafting periodic safety update reports, their submission and PSUR cycle. So, periodic safety update reports should be submitted to the regulatory authorities. It also contains time frames in which these reports should be submitted to the concerned authorities. Unexpected and serious adverse effects in clinical trials are to be reported by the investigator to the sponsor and to the ethics committee within 24 hours and 7 days respectively. Unexpected adverse effects should be reported within 24 hours. Serious adverse effects should be reported within 7 days by the investigator. Investigator is nothing but physician who is conducting the trials, to the sponsor and to the ethics committee. So, the sponsor will be providing funding for the clinical research, clinical trials, and also ethics committee will be taking care whether the clinical trial is conducted in an ethical way or no, with the consent of the volunteers, human volunteers or no. This will be taken care by the ethics committee. These should be reported by the sponsor. So, whatever reports the investigator is giving to the sponsor and the ethics committee, they should be reported by the sponsor to the licensing authority within 14 days of occurrence. Pharmacovigilance for generic industry in India. The generic drug already has a prototype in the form of innovator branded drug with which it is compared for its pharmacokinetic properties. So, innovator drug or branded drug. So, one of the pharmaceutical company tries to introduce a new drug. They try to bring up a new drug. So, they will be doing phase 1, 2, 3 clinical trials, and and then they will be releasing the drug into the market. Before releasing the drug into the market, they will be taking a patent for a stipulated time period like 10 years, 15 years, 20 years, like that. So that's why it is called branded drug. So what is generic drug? After the patent of the pharmaceutical company expires, so after that time period is over, the drug can be manufactured and marketed by any company, any pharmaceutical company. That is generic drug. So since generic drug already has a prototype in the form of innovator, since all the tests have been done in phase 1, 2, 3 and phase 4 studies also will be done by the branded drug, with which it is compared for its pharmacokinetic properties. So generic drug already has established studies from phase 1, 2, 3, 4 and this generic drug will be compared with its prototype, that is branded drug, for its pharmacokinetic properties. The safety data should be similar for both innovator and generic drugs, but it is always better to monitor ADRs, if any, produced in the population upon usage. Post-marketing surveillance should be strong enough in such cases. As India is more involved in the production of generic drugs, the industries follow the procedures of monitoring of ADRs, collection of such data, reporting of spontaneous and serious unexpected ADRs, and preparation of periodic safety update reports, PSURs, for their products. Preparation of PSURs by the industries include vast literature review. So while preparing the periodic safety update report, they have to go through literature review, all the previous studies, and research work should be reviewed. Management of safety profiles of drugs, detection of ADRs, and analyzing the benefit to risk ratio of the products. Then current system of reporting ADRs in India. All the reports including safety reports, reports obtained through post-marketing surveillance, serious adverse events from clinical trials, and reports from the zonal pharmacovigilance centers and individual reports from hospitals, physicians, patients, etc. are submitted to the Office of the Drug Controller General of India, where they are saved in the form of databases. These are made available to research institutions and pharmaceutical companies. The reports from the Office of DCGI are submitted to the National Pharmacovigilance Advisory Committee, taking decisions regarding safe drug use. If they find that a certain drug is causing severe side effects, serious side effects, and if the proportion of the side effects is high, if the percentage of side effects is high, they will be taking a decision to ban the drug also. Requirements for reporting ADRs. So what information is required for reporting an ADR? First is patient information, name or record number, that is IP or OP number of the patient, date of birth, sex and weight of the patient are required to be reported. Then details of the adverse reaction, date of onset of the reaction, time required for reaction to occur from the date of administration of the drug, and a brief description of the ADR including the affected body part. Severity of the reaction, etc. are required. Other relevant information like medical history of patient, laboratory tests done and the results obtained should be clearly specified. Then information related to suspected drugs. Following details about the drug suspected to cause adverse reaction is needed. Brand or generic name whichever is available, strength of the drug, batch number, expiry date, reason for use of drug, dosage form used, route of administration, dosing frequency, duration of drug therapy, and details of other drugs used simultaneously with the suspected drugs. So those drugs are called concomitant drugs. Drugs that are used along with the suspected drugs are called concomitant drugs. Details of the medical devices used, if any. Then information about management of ADR. Reasons linking the ADR to the suspected drug should be specified. So why does the reporter think that ADR is caused by the suspected drug? So the reason should be mentioned. Reasons for regarding the ADR as serious should also be mentioned along with the treatment given to reduce the reaction and the results of treatment. Then reporter information. Reporter's details like name, contact number, signature are required. Date of reporting of reaction and address of the hospital, institution, etc. where therapy was given is also required. Then this is the suspected adverse drug reaction reporting form from CDSCO, Central Drug Standard Control Organization. So here in red you can see patient information is required, suspected adverse drug reaction, suspected medications, then reporter details. These are the important fields of information required. Then what to report? All adverse events should be reported. Report non-serious, known or unknown, frequent or rare adverse drug reactions due to medicines, vaccines and herbal products. Report every serious adverse drug reactions. A reaction is serious when the patient outcome is, if the patient is experiencing death or a life-threatening condition, or if the patient's hospitalization, if the reaction is leading to hospitalization of the patient or prolonged hospitalization of the patient, if the reaction is leading to disability, significant, persistent or permanent disability, or if the reaction leads to congenital anomaly, birth defect, report intervention to prevent permanent impairment or damage. Then serious or adverse event following immunization, that is vaccination, can also be reported in serious AEFI case notification form available on http www.ipc.gov.in. So who can report? All the healthcare professionals, clinicians, dentists, pharmacists and nurse etc. can report adverse drug reactions. Also the patient can also report the adverse drug reaction. Where to report? Duly filled in suspected adverse drug reaction reporting form can be sent to the nearest adverse drug reaction monitoring center AMC or directly to the National Coordination Center NCC for PVPI, Pharmacovigilance Program of India. So every hospital will be having peripheral pharmacovigilance center. The healthcare professional or the patient can be reporting the ADR to the peripheral pharmacovigilance center. Or there is a helpline. We can call on helpline toll free number 1800-180-3024 to report ADRs, or directly mail the filled form to pvpi.ipc@gov.in. So a list of nationwide AMCs is available at http www.ipc.gov.in. So there we can find a list of nationwide AMCs where we can report the ADR. What happens to the submitted information? Information provided in this form is handled in strict confidence. They will be maintaining it confidentially. The information will be in between the healthcare provider and the healthcare professional and the patient and the Pharmacovigilance Program of India. The causality assessment is carried out at AMCs by using WHO Uppsala Monitoring Center scale. So whether the drug actually caused the ADR or no. The ADR can be due to, the adverse event can be due to any condition, any disease condition or food or anything. So they will be doing causality assessment using WHO Uppsala Monitoring Center scale. There are other scales also like Naranjo scale, but they will be using WHO UMC scale. The analyzed forms are forwarded to the NCC PVPI through ADR database. Finally, the data is analyzed and forwarded to the Global Pharmacovigilance database managed by WHO Uppsala Monitoring Center in Sweden. The reports are periodically reviewed by the NCC PVPI. The information generated on the basis of these reports helps in continuous assessment of the benefit risk ratio of medicines. The signal review panel of PVPI reviews the data and suggests any interventions that may be required. Then mandatory fields for suspected ADR reporting form. Patient initials, age at onset of reaction, reaction term, date of onset of reaction, suspected medications, and reporter information. These are the mandatory fields to be filled in. So there is also an ADR mobile app, which is ADR PVPI, to report the adverse drug reactions. Along with mail and helpline toll free number, there is also a mobile app to report the ADRs. Then spontaneous case reports. Spontaneous case reports are the unsolicited cases of drugs in market that are reported to the company either by consumer, lawyer, nurse, pharmacist, prescriber, or sales representative of a different company. Unsolicited means unasked reports. In isolation, these reports exhibit information of limited importance. So single report may not exhibit much importance. However, they prove to be important when these are clinically confirmed by the prescribing physician. The adverse effects that are spontaneously reported can be considered as drug related, even though the report is only used to inquire about the drug, whether it causes any adverse effects in patients or not. In certain situations, a case report from patient describes the adverse effects, including positive rechallenge, which is very important information that plays vital role in safety profile of drug. So even when a patient is reporting an ADR, so if the ADR is showing positive rechallenge, there are terms like dechallenge and rechallenge. So we are administering the patient with a drug X. Suppose we are administering the patient with a drug X and the patient is experiencing some adverse effects, and we are withdrawing the drug, we are stopping the drug. After withdrawal of the drug, if the adverse effect is reducing, then it is called positive dechallenge. Dechallenge is positive. Then after some time, we are again reintroducing the drug to the patient. After reintroducing the drug to the patient, if the patient is again experiencing adverse effects, this is called positive rechallenge. Generally, the spontaneous case reports describe type B reactions instead of pharmacological side effects. As the database of these reports are unsolicited, these databases cannot be used in providing an accurate incidence of adverse effects, even type B, because all cases reported are by someone who acts as reporter and are unqualified and cannot recognize the case as an adverse reaction in patients. So since these unsolicited reports or spontaneous reports, they do not do causality assessment before sending the report. So we cannot say whether the drug has exactly caused the ADR or no. The adverse event could be because of any other disease condition or because of food or any other factor. So So these unsolicited or spontaneous reports, they do not provide accurate incidence of adverse effects. Sometimes some cases are reported not because of drugs but due to change in reporting pattern from time to time since their launch, also because the rate of reporting of a particular adverse effect usually increases after publication of signal. The spontaneous reports can be advantageous when they are received properly and thus provide important signals. So when the spontaneous reports are reviewed properly, if there is a proper review done, and they can provide as important signals. Not only they have occasional individual importance, but they also exhibit consistency of time of onset and pattern of presentation that are important as well. The database of this overview is facilitated by Pharmaceutical Health Organization WHO. The database nowadays is stored electronically, example imaging, and eliminate the paper transmission of case reports. During the analysis, the standard coding dictionary of adverse effect terms and the method which is accepted as the gold standard, that is MEDRA, Medical Dictionary for Regulatory Activities, is used. So we are storing the data electronically. So to store the data electronically, we need to code the adverse effect term. So coding is done using MEDRA, Medical Dictionary for Regulatory Activities. Coding of the adverse effect term is done using MEDRA. However, it is important that the routine review of cases should be done by experienced and responsible reviewers for identifying new signals and to ensure patient safety. Thank you. Please like, share, comment and subscribe to my channel. Press the bell icon for more notifications.